So,
Okay,
Seth, you want to start?
sure. So this is a case we just had. Um, this well, we just had it recently in terms of the what we had here. So I'll just show the chest first because it's you got ascites, you got a kind of ugly looking liver, kind of looks edematous, and then we see this what you think is kind of typical as it gets a continuation, but it's actually is, but it isn't. So this person had, so I'll show you the body portion of the scan. Um, and so there are these systemic iliac veins. They're completely thrombosed. There's a little bit of contrast kind of layering around the edges of them. You could see at the level of the renal arteries, there's reconstitution. There's also all these collaterals. Then you can see as we get to the intrahepatic segment that there's complete absence, thrombosis, atresia of the intrahepatic segment. So this person was actually diagnosed, and this is the diagnosis she's been treated with here as congenital absence of the intrahepatic portion of the IVC. That we were looking it up. It comes from a separate remnant, the vitelline vein. The suprahepatic portion is present. The intrahepatic was absent. They actually took her to surgery and tried to create an IVC, reconstruct it. There really wasn't much there. It was just a band. They describe it as kind of a ligamentous band of tissue. And what's interesting, if you think about it, so everything that we see filling actually the infrahepatic IVC from the hepatic veins for the most part, although there is some flow into the suprahepatic IVC through a little bit of flow through these some hepatic veins, that in fact this flow into the IVC, infrahepatic IVC, is actually retrograde. So it's going from the hepatic veins down to the renal veins and then filling through all these collaterals retrograde. And as we go on later in life, they've tried to create an IVC in the intrahepatic portion. It didn't work very well. It basically never really opened up, and she's continued to develop these massive collaterals, and it's fascinating. These collaterals, you can see them extending from intra-abdominally going through the musculature, through a small defect into the soft tissues, and now we have this huge kind of spleen and big liver. So, you always wonder if these are congenital or acquired, but she has a diagnosis of congenital atresia of the intrahepatic IVC, which we've never seen before, but pretty impressive collateralization, to say the least. And I'll show. Yeah, I don't know if anyone else is. We've never seen that.
So, Seth,
Yeah.
why were all the collaterals there then from the beginning of life? Why is there this ongoing process of developing more collaterals? Doesn't that suggest something acquired later?
Well, she's continued worsening thrombosis, and now before where she had, I think, some venous flow um, into her IVC to drain her hepatic and renal veins, which then went through collaterals. Those are now pretty much completely. There's more thrombosis, basically. The IVC at least held some contrast before in some route, or whatever was remnant of the IVC lower down, and that is completely thrombosed. And the answer as to why they're getting worse, we're not sure. And again, this is just what the given diagnosis was. She was supposedly diagnosed at a young age with this and waited until she had symptoms, which were, severe swelling, edema, dyspnea, liver failure, until they decided to try to fix it. And your answer is valid. And we're just going off what her given diagnosis is based on her history and her surgical intervention. But it could be, we are assuming it's worsening thrombosis due to the initial insult, which was absence of this intrahepatic portion of the IVC.
Got it.
But we could be wrong. I mean, we were kind of looking at this for a while, and we could be. If any of you guys have other ideas, it's completely possible. We were just saying we hope that no one nicks her skin. She might, it's pretty amazing, these huge vessels. Do you have another idea? I mean, do you have another?
I wonder if it's acquired thrombosis of the IVC.
Yeah, and that's what I think the initial thought was. But I think when they went in surgically and looked at what was the portion of the IVC in the belly within the liver, they determined that it actually never developed. That was the surgical determination, and honestly, it could be wrong.
Okay, thank you.
So this is I can never remember what this one's called, but it's pretty characteristic. This is a guy who has been here for some time. He has a known diagnosis of this mediastinal. This is not proven yet, although it kind of is proven. This diagnosis of this kind of infiltrative mediastinal mass. It's surrounding everything. It's really not pinching anything off. He is, you can see, he has a lot of atherosclerotic disease, some stents. He's also a renal player. So this guy underwent multiple biopsies of this lesion, got back nothing except for kind of normal lymphatic stuff. And then you could see that there's this pronounced thickening of the peribronchovascular interstitium with septal thickening. Supposedly this guy has had this for an extraordinarily long time. He's 20-something now, but supposedly he's had this for decades. And we are assuming, based on another case we have that looks similar, and also just from similar appearances that we've seen in texts and the rare cases, that this is a case of this congenital lymphangiomatosis, or I can never remember. Jeff, do any of you guys remember the exact name? It's you just get this large kind of infiltrative lymphatic malformation. You get lymphatic malformations through the lungs.
Two different ones. There's lymphangiectasia, which is the dilation of the intrapulmonary lymphatics, which often is fatal. And then there's lymphangiomatosis, which I think is what you're showing here. It's just all these lymphatic malformations.
Yeah, we called it congenital lymphangiomatosis, but I'm never sure if that's. I always get confused with these malformations.
But bone lesions, right? That I can see.
No, he didn't. We were wondering if it was Gorham's or something like that. He had no bony lesions. Actually, I asked my fellow the same thing. I said, "Do you have any bony lesions?" But there weren't.
No, and no pleural thickening is part of this. Is that left pleural a little bit thickened posteriorly, or is there effusion back there?
Not really, not much.
Yeah.
And no splenic lesions either.
Yeah, no splenic lesions.
We had two cases of lymphangiomatosis. They were both in young women. They presented in their 30s, and they didn't do well. They died in their late 30s or early 40s.
Oh, did they? Yeah, we have this guy. I think is 23, 24. He's had this known for a long time, but didn't really start. Was having more symptoms from it as of late. And I don't know if there's probably no I can't imagine there's a good treatment for this. So that was a cool case. And then lastly, this is just a interesting / bad case. So this is a and I apologize if it looks. This is the 70 keV reconstruction. So this was a guy who had a type A dissection outside hospital. They tried to fix him with a root replacement and reconstruction of his RCA, and you could see it's pretty bad when you basically thrombose your whole ascending aorta. And I was called one night. One of my fellow attendings called me and said, asked me to look at it, and it kind of struck me. I think it's easier to see on the delay, but it kind of struck me here that to go along with, I mean, the guy just has a nightmare of a condition, but to go along with the that heart, the fact that the aorta is pretty much occluded and there's almost no coronary artery flow, you can see that there's a subtle or not so subtle subendocardial perfusion. Now, if you go to the delay, it's even more pronounced. So here we now have filling of the PA. The aorta is pretty much occluded except for this elephant nose graft, or it's another term for this elephant graft that's trying to feed the coronaries coming from here. And then now we can see on this little bit delay that there is, you know, you always say if you see diffuse subendocardial enhancement, it's never usually coronary disease because you wouldn't be alive. Well, this guy is the one exception. So he did basically infarct his whole heart, and had a troponin that was in the 180s or something, 160s, and a little bit of sparing maybe there in the distal RCA, but basically developed an EF of 5% from this massive infarct and eventually died. So, you know, I've just never seen such an extreme myocardial injury. And this guy was alive for a while. They kept him alive on ECMO and other methods, but basically acute infarction of the entire coronary artery tree. So bad news. But all right, those are my cases.
All right. Well, thanks. That was impressive. All right, who's next?
I've got a few, Jeff, that I could show.
All right.
This is one I'm going to show just because I have a biopsy to go along with that. So this one is a question of interstitial lung disease of some kind. So let me show you some images of it. I have some thin cuts. So I'll just scroll up and down. We obviously already up here have subpleural cystic spaces consistent with traction bronchiectasis and bigger spaces consistent with honeycombing, reticulation, quite extensive in the upper lobes already, but more of the same. And when we get down to the lower lung zones, there is clearly reticulation. There's actually some traction bronchiectasis in the lower lung zones rather than immediate subpleural bronchiolectasis, honeycombing. So certainly with respect to the lung bases in the form of subpleural bronchiolectasis and honeycombing, it's relatively unimpressive, and the involvement of the upper lung zones is rather impressive, at least with respect to subpleural bronchiolectasis and honeycombing. So not typical for UIP. Here's the path report, and certainly the path report here, which I'll blow up from the pathologist, really came down pretty strongly on chronic hypersensitivity pneumonitis as a pathological picture. So you can read that there, but I think in terms of the imaging and trying to correlate the imaging with the path, I think it fits quite nicely. And, you know, I'm quite comfortable with the suggestion that this is not UIP, but chronic HP, even though, as we know, that oftentimes you can't find the antigen. So it's kind of an interesting rad path correlation, but I presume none of you guys would be feel that this is not consistent with what we see on the imaging.
Although, Howard, I would point out this is a nice example of discordance between CT and path. And they did mention features of UIP, which we see on the CT scan. Because, you know, sometimes you see the honeycombing in the upper lobes and not necessarily in the lower lobes, but the disease is still basal predominant overall. Did he have any air trapping on his expiratory images?
Let's have a look and see what I have, if I do have that.
It looks like you have some. That's why I asked.
Yeah, I do. So here's a couple images. Not particularly, huh?
No, not really. And it often does go away with more severe fibrosis, has been my experience. I don't know, David, what do you think of this case? How would you have read this without the path? I think I would have called this UIP.
I would have called it UIP. This is always, and then you get the issue because chronic HP is UIP,
right,
pathologically. But I would have called this, I would have thought it was IPF, like, without it.
There's nothing funny about it, because usually with HP, especially in the upper lobes, you tend to see more peribronchial fibrosis as well, and it looks pretty clean, potentially. David, what do you think?
I'd say peripheral fibrosis with honeycombing, so it's a UIP pattern. And the question is it UIP caused by IPF, or is it UIP as a chronic stage of hypersensitivity or some other insult? Yeah. So I think it's a UIP pattern. The question is what triggered it.
Yeah.
Okay.
Did he have exposures, Howard?
No. The clinical record was really unrevealing from that point of view.
Interesting.
So why did they think it was I'm sorry, did they say because it was just airway center, that most of the fibrosis was centered around the airway versus...
Exactly. If you... let me see if I can bring this up so that doesn't do that kind of nonsense. Let me try and bring that up.
Airway center with fibrotic stuff, though.
Yeah, if you look at that, fibrosis often airway centered rather than.
Usually, though, there's they mentioned the chronic inflammation around the airways. That's one of the key features. It had it had all three features: granulomas.
Did it say where does it say granulomas? I'm not even seeing it.
Loose interstitial
granulomas. Yeah.
Yeah.
You know, which doesn't always.
But unfortunately, our pathologists always say that you can always see a few scattered granulomas in anything.
Right.
That's weird. I would personally, I would have not thought of HP for that. I would have just called it.
Yeah.
But something must be a biopsy, because typically these wouldn't even go to surgery. But on an interesting note, the presence of fibroblast foci on the path and features of UIP in the honeycombing on the CT both don't portend well for the patient. I mean, portend a poor prognosis, but at the same time, the discordance actually is somewhat better. But obviously not someone you're going to give pirfenidone to.
Yeah.
Wow.
Interesting. Yeah, just like there's intra-observer variation in radiology, of course there will be in pathology too.
Right. And that's the interesting thing. You know, there's almost no good studies out there with pathologists doing that. You know, we have a ton of stuff with the RADs. I think there's one study that has, I don't know, two guys, very famous guys, I can't remember, but it's old, looking at even UIP to NSIP. And they went through like 15 cases, that was it. And their kappa values were like 0.4, 0.5.
Yep.
And that's it. There's nothing out there on how they agree with each other. And we know they don't.
Right. Yep. You can see this person's really emphasizing the fibrosis involving the entire lobule without adjacent uninvolved lung.
Yeah.
From UIP.
It's a very nice description of what you see with it.
Yeah, definitely trying to make that distinction, which I really like when they do that.
Yeah.
This is our pulmonary pathologist, and she really tries to get into these in a more detailed fashion, and often sends me their description and asks me whether the imaging findings are consistent with, or is there a huge dissonance and so on. But you can see it's a nice description.
Yeah.
Yeah. Good. Let me show you this one just out of interest. Here it's important to know when you interpret this kind of scan the context of the patient. So let me show you this, which is this one here. So let me just scroll through this a little bit better. So the area of interest in part for the person interpreting these exam was these two lesions. So here, these are 5 millimeter cuts. So here's a cavitary lesion, and here's a small cavitary lesion. Let me actually bring this up in thin so that you can see what they look like a little bit better. Sorry, my mouse is not cooperating very well. So let me just go up there. Ignore the rest of the stuff in the lower chest, which is not relevant. But here's item number 1, and item number 2 is right there. And these are new from a previous CT scan. And here we bring up the previous, sorry about that. Let me try and get disconnected. Bring this one down. And so this is new from before. And it was suggested in the differential diagnosis that this could represent cavitary infection. But the key piece of information that wasn't readily available was the fact that the person had a transbronchial biopsy. So based on some outside information as well as some findings, sarcoidosis was a consideration. And let me just stop these from scrolling together. Based on the previous exam, and basically they did the transbronchial biopsy, but they did it in the right upper lobe, and that's the key piece of information. So these are really typical bronch bites, so-called. They have a little bit of, presumably a little bit of hemorrhage around them, but otherwise they're pretty consistent with so-called bronch bites. Sometimes we see them later on when they're just cystic lesions. This one has got presumably some hemorrhage around it. But in terms of what they did and the timing of it, these are so-called bronch bites, not to be confused with any other pathologic process right there. Have you guys seen these in the fairly acute setting when they might have a little bit of hemorrhage around them and therefore simulate things like septic emboli or cavitary infection and stuff like that?
Yes, in one of our transplant patients one time, and ours were more sort of ellipsoid, more elongated, and
okay,
that was done by one of our interventional pulmonologists. I find they take a little bit more generous samples.
Okay.
So there were a bunch of them, but it was exactly, you could follow them almost out of the airways.
Yep. Okay.
The other thing is that we've seen a couple of these, and they get near fissures or external pleural surfaces. You can see how you can get a pneumothorax following transbronchial biopsy.
And David, that's what happened to this patient, is shown in this radiograph?
Mm-hmm.
Yeah, exactly. Got post-biopsy pneumothorax too. So quite an adventure. Okay, so you've got some bronch bites there. Let me show you this one. So this is a exam from, let me see, make sure I've got the right. Okay, so here we have a person with multifocal multilobular disease. Notice that we have nodules. I'll give you a sec just to look at the distribution of these small nodules. Some of them are peribronchovascular, some are subpleural. Here, of course, we have the largest one, and this one is obviously cavitary and quite large. There's a little calcium associated with it. So this was suggested to be maybe sarcoidosis. But while some of the other nodules are certainly consistent with that, I wouldn't have liked this for sarcoidosis with a kind of a dominant cavitary lesion. So that was then, and the patient returned later with some symptoms. So that's 2015. And at the time of the symptoms, this being this year, we now have that lesion, which is actually a bit smaller, but now we have new lesions, one up in the left lung apex, and we have new lesions here in the posterior segment, and additional ones in the right lower lobe. So I was really concerned about tuberculosis, and this person did turn out to have sputum-positive TB. So he was under the custody of our legal system, and what's the word I'm thinking? Not legal system.
Correctional facility.
Exactly, yeah. So yeah, this should worry you. This cavitary lesion I don't usually associate with sarcoidosis.
So I think this makes a good point that you're pointing that cavity out, because, I mean, you can get cavities with sarcoid, but they're associated with scar, volume loss, the ones we see aspergillomas in. And if you look at your initial CT, it's more of a mass that's cavitated. There's not a lot of distortion around it. And that should, because you can get big masses in sarcoid, but that should raise some red flags. Plus, it's strikingly asymmetric.
Yeah, it is.
It can happen, but not typical.
Yeah. So an interesting case of tuberculosis. Yeah. Okay, Jeff, those are my cases for this week.
Great. David or Brett?
I can show one case. Aligned with with Howard's case. This is a Kenyan woman, I think in her 40s, actually 50s, who had some constitutional symptoms, fever, cough, night sweats, has an abnormal chest radiograph here with some consolidation, probably some mediastinal widening here too on the left. And this stripe over here, although it's not convex, is too dense for normal. That suggests that there's some process here on both sides of the mediastinum. Has pleural effusion on this side and smaller pleural effusion here. Then on CT indeed does have cavitary nodules in the left upper lung, elsewhere as well, lots of motion artifact, and then quite a bit of low attenuation lymphadenopathy in the mediastinum here, and continuing down into the abdomen. Here's our mediastinal lymphadenopathy again, and splenic lesions, and then a ton of abdominal lymphadenopathy down here, all low attenuation. So this was MTB, and this woman had HIV, and a lymphocyte count had been measured a few years before she declined therapy, but her lymphocyte count when it was measured years back was only 4. So she has no lymphocytes. And this low attenuation lymphadenopathy, we saw a lot of this in the AIDS era, from associated with mycobacterial infection, MTB or sometimes MAC, Mycobacterium avium complex, both sources of low attenuation lymphadenopathy. So she's got this massive lymphadenopathy here, splenic lesions, and she had duodenitis that was biopsy proved to be tuberculosis. So she had some gastric obstruction. She was scoped, she had duodenal inflammation, biopsied, and it was TB of her duodenum, so she had TB all over the place. She also, I think, had meningeal TB eventually too. So widespread TB in a HIV positive African woman here. Like the old days.
Yeah.
Oh,
okay.
All right, David, thank you.
Everybody put on your mask.
Let's see. Brett, do you have cases? I don't think you can hear us.
Yes, I have a couple.
Yeah, here, go ahead.
Okay, let me
sequence into your mediastinal.
Okay. So just a couple this week. This is a
Soft tissue density likely
young patient who has follow-up here with us for Williams syndrome, and had a, the things that we're familiar with Williams syndrome are a supravalvular aortic stenosis, and this patient had already had repair of that at this time, and you can see the sternal wires here. They had this done on a remote basis. But what I'm really interested in here is if you look at the right pulmonary veins, they look very normal. But look at the left pulmonary veins here. You have this very narrow waist, and then you have this dilatation of the remaining pulmonary vein. And then same thing for the superior pulmonary vein here. Just looks dilated here, or even maybe normal size, and then very narrow here. So in this setting, we always think about, of course, pulmonary vein ablation for atrial fibrillation, but this patient had not had that done. And I'm not showing you the other CTs they've had, but in the past, these stenoses were seen as well. And what I really didn't know at the time was that not only can Williams syndrome give you supravalvular aortic stenosis, but also it can give you congenital pulmonary vein stenosis, and this is one of the first ones that I've seen where that was actually the case in the case of Williams syndrome. So again, no pulmonary vein ablation in this patient. There's just a congenital set of pulmonary vein stenoses here in Williams syndrome.
Wow.
Have other people seen that?
So like a hyper.
I thought you were going to show me a case of sarcoid pinching off the pulmonary veins, and I showed one a few weeks ago, and I was hoping other people would come up with their sarcoid-induced pulmonary vein. But there's no tissue surrounding this.
Sorry, I'm going to bring that case. I forgot to do this week, but I'll bring it.
You promise?
Yes, I do promise.
Then it's an email reminder, David, because I think I might have one too, but I forgot to look for mine.
Okay.
But I thought that was interesting. And here's another case that I thought was really interesting. And this is a patient who you can already see, has a huge right atrium and right ventricle.
Your screen yet?
Yeah, sorry about that. There we go. Okay, so this patient has a huge, absolutely huge right atrium, and the heart itself, the other chambers are enlarged too, but particularly the right atrium. And we were taking a look this one day, and Dr. Stillman here showed me this case. And at first we wondered, you're looking at the AICD coming across, and you have, this thick thing along the course of this AICD lead. And so, my first thought was, could this be thrombus? But of course, I wouldn't just show you a case of that. It's very well defined too, and it's most unusual looking thrombus that you might ever see along an AICD lead. So it's not thrombus. But if you look here, you can see that the tip of this thing. And I'll show you well, shoot, I don't have the scout here. Let me show you the coronal though. So you can see here on the coronal that I've actually misled you a little bit, because this is not really an AICD lead. This is actually a device called the Forma device, and I can't be sure if someone has shown another case of this in the conference so far, but this is one of the first cases I've seen of it. And what this is it's a inflatable polymer-like device that has an anchor here that's supposed to anchor at the RV apex. And this polymer, this inflatable polymer, is supposed to traverse the tricuspid valve annulus and the valve itself. And theoretically, it allows a space for coaptation of the tricuspid valve leaflets, and also decreases the area of the valve itself, so that this theoretically, and it's been in studies, helps decrease tricuspid insufficiency. And let me show you what that looks like. Can you see the internet?
No. So basically, this is misplaced because it's not at the tricuspid valve.
Well, let me show you. Yeah, here we go. Can you see that?
Yes.
Okay.
Wow.
Okay, so this is an artist's rendering of this Forma device. So yeah, I mean, Seth is right. I was showing you that the anchor of this is displaced because it's not at the apex, and it's supposed to traverse the tricuspid valve, giving both occluding, to some degree reducing the area across the valve, and also giving the leaflets room to coapt there, some surface on which to coapt. So anyway, so we're going back to the CT. This is let me go back to the window here. This is displaced, so it's off the anchor here. The anchor has been withdrawn a bit, or it's come up a bit, and this thing is displaced. So just an example of a displaced Forma device. So have other people been seeing those yet in their institutions?
Nope, not at all.
Never.
Nope. Is it like FORM something?
Yes, sorry, it's FORMA, the Forma device.
Edwards Forma device.
It's a, you place this through a percutaneous approach, and that's what it should look like in the prior image that I showed you. So, but anyway, those are the cases I have this week.
Great.
All right, thank you, Brent. So David, let's see what's going on. I don't want that. All right, I'm downloading my sarcoid case for David. No, I don't want to hit that button. Let's see here. It'll be down in a minute. So let me start with another case. So this goes back to our discussion next week. And hold on, I will share the screen as soon as it appears. And I want to show you this. All right, so we were talking about the azygous vein last week.
Yes.
This is a case where, so this is the original scan. It was a acute traumatic injury, and we can see there's a big pneumothorax, and you see the azygous vein is hanging outside of the fissure, and the lung is pulled away from it. And so I thought maybe on the follow-up, it would have, the lung would have come up and the azygous vein would have gone back to the mediastinum or something. But interestingly, as the lung came up, it went back, the fissure went back to where it was supposed to be. So this is the opposite of what we were talking about last week. And I funny, because I came across this case right after we were talking.
So you're saying that the azygous vein
Popped
had
out.
been outside, went in?
And went back in. So this is after. And this
Yeah.
and I don't know if it came all the way out, but it definitely pulled away from the lung. So here's your collapsed upper lobe, pneumothorax. There's the mesoazygous going right there. And,
Right.
And see the vein sitting on top, like the case I showed last week where it sat on top and then moved away. In this case, you see it just goes right into the posterior mediastinum here. In this case, it popped back into the vein. I mean, the fissure popped back into the lung. So it's probably not a complete separation at the time. And as the lung came up, it just took the path of least resistance. But very cute.
So this is reincarceration of the azygous vein then?
Yes.
This is okay.
Now here's my sarcoid case for you, David. Let's share it. So let me show. This is 2013, and you can see the pleural effusion, thickening, and extremely tight pulmonary veins, lymphadenopathy, all the way up. So good picture for sarcoid. But you see the pulmonary vein stenosis, right? So before this patient got into too much trouble, they actually were able to stent these veins, some of them. So you see they put a stent in on the right superior, left inferior. Not great flow inside that stent. You can see it's pretty tight, and they're still pretty tight. It still has the pleural effusions and some other stuff going on there. But this is I've seen a few cases of sarcoid do this. This is the one.
Wow.
And I have one on my server that's from Howard, so he had one case as well. I didn't download that one though.
So Jeff, what's your interval here? What year is this now? We're 2013 for the first one.
About a year and a half later.
So
the initial one is the lung edemas, interstitial edema, pleural effusion.
There is.
Venous hypertension.
Yeah.
Oh, there's some up there. Ooh.
I wish I had radiographs, but I don't. There's probably less edema in the lower lobes because there's less flow down there.
Huh.
Or there's better drainage, one of the two. It's pretty tight.
Very impressive, Jeff.
All right.
And also, this case is like the one that I think is sarcoid from here.
Yeah.
But the lymphadenopathy is amorphous.
Right.
Normally, sarcoid lymphadenopathy is very well defined, has clean borders against mediastinal fat, but your case and my case both have this just amorphous lymphadenopathy with...
Right. So what I suspect is mediastinal fibrosis from sarcoid, and where it differs from mediastinal fibrosis from histo, where you get a big, solid, ugly, calcified mass.
Got it.
All right.
Jeff, be sure to post this case because I want to show the people here to...
Yeah, I will fix my networking issues. Okay, well, here's an airway case that was kind of a neat case. Let me show you guys. All right, so this is a patient who had a lung transplant, solitary lung transplant for fibrosis. This is back in October, and you can see the bronchial anastomosis looks very happy. No stenosis, typical appearance. Patient was having some spirometry issues, and so we did a CT scan later. So this is now December, and you can see it's narrowed. And if you throw it on a coronal, you can see it's quite striking, but it's cut down about by 50% at the anastomosis. Nothing really else. But we did do some expiratory images. We do them routinely on our transplants. And what I thought was kind of interesting is it looked to me like there was almost global air trapping. It didn't look very expiratory. on the side, but you look at the airways, clearly it's an expiratory CT. So I think there was more of a global air trapping that was hard to see it, but so not at the lobular level. And then here are the bronch images pre-stent, and you can see just how tight it was in there. So there's the right main. You see how tight that was, and this is it down there. So nice correlation with bronch and CT. And the bronch was done the next day. So, and then they ended up putting a stent across it and opened right up. And I can't remember how far out the patient was from transplanted. I think it was about, I want to say somewhere between 6 and 12 months. This is an impressive case because this is a diagnosis we more often see in children. And this is, let me show you here. So this is a young woman who presented with shortness of breath, fever, and a bunch of other sort of systemic symptoms. Presents with this anterior mediastinal mass, pleural effusion. Underwent a CT at some other hospital, and you can see this really ugly, heterogeneous mass with some significant mass effect on the adjacent structures. And there's some consolidated lung down here that looks very unhappy, probably a post-obstructive infection, pleural involvement. There was a drain already in at this point here. And so, in adults, we think about thymic tumors, although she's kind of young for that. We think about germ cell tumors, but they're usually benign in women and they look like teratomas. Lymphomas are usually more homogeneous, especially the diffuse large B cells or Hodgkin's. But this is a case of T lymphoblastic lymphoma, which is one of the more common anterior mediastinal masses in children. So she's kind of on the older end of this. And actually, interesting, I read a CT on her the other day, and this is all regressed now and looks like normal thymus. So it responds very well, but it actually involved the pleural space and everything and just moved really, really fast. And I don't have the images, but she ended up developing a small pulmonary embolus because one of the drugs they used to treat this, some variant of asparaginase, is prothrombotic. And she ended up developing just a little tiny one in there, but you can get that. So this is just T lymphoblastic lymphoma as an anterior mediastinal mass. If she were 30, I would have gone with diffuse large B-cell lymphoma. David, this is for you, and Howard, this is for you guys. I think you'll like this case. And Chris Meyer gave me this case. This is an engineer who works locally and who's been exposed to a lot of beryllium. And there was nothing in the lungs, but Chris made a great observation that you can see the lymph nodes in the mediastinum are actually pretty dense, and it's not artifact, and it's all of them. It's pretty consistent. They're not enlarged at all. So probably is, we can see that with early sarcoid, but I suspect there is beryllium or beryllium, granulomatous inflammation related to beryllium in the mediastinum. This woman was from South Central Asia, so sarcoid is very uncommon in that population. So with that occupational exposure, this is probably the lungs doing what they're supposed to do, and that's clearing the dust, and then she's getting a granulomatous reaction to it without developing parenchymal disease. And it's the only time I've seen beryllium disease with presumed berilliosis without lung involvement. I don't know, David, you probably see some from Hanford. And I know Howard, beryllium.
I don't think I've seen calcified nodes, but it makes a lot of sense. I mean, it imitates sarcoid in so many ways.
Right. And I think it's just one of the causes of sarcoid, but it may not even be calcium. For all we know, there could be beryllium, but it's so low molecular weight. I suspect it probably is just calcium. And if we biopsy,
what about other hard metals? I've seen aluminum do this.
Exactly. I have a case of aluminum.
But she has no exposure to that or any other hard metals?
The one of concern, she had something with metal alloys and stuff. We didn't have the exact exposure, but beryllium was high on the list there. So very young woman. You can see still has normal fine.
Anything in the upper abdomen, Jeff?
What are you looking for?
Any high attenuation nodes?
No. But most of our sarcoids tend to not get too much abdominal involvement that we see. I don't know.
Right.
But it shows you that the lung, that's probably why sarcoid early on presents with lymphadenopathy. The response to whatever antigen it is for that person is
right.
It's cleared, and then you don't get lung involvement until you overwhelm the central lymphatics. All right, and then this is a nice case of pulmonary hypertension. I'll share you. Let's see. No, that's not what I want to do. So you can see little generous on the heart. Pulmonary artery is a little plump, and there's a little bit of hypoperfusion there. CT scan shows right ventricular hypertrophy, enlargement, and this I think is an outside scan. But you can see there's, as I scroll down, there's a couple little webs and areas of segments that aren't well perfused. Right here, you can see kind of a little small vessel and then a little bitty web here, but not a lot in the way of central thrombus. But the VQ scan is quite striking. You can see a lot of little peripheral defects. But here's the ventilation, which is pretty homogeneous, old style, sort of xenon. But you've got all these little rat bites. Typical CTEPH. So while we like CT and we're good at finding webs, stenoses, there's still a good role for VQ scanning, and the guidelines still recommend it. And look at this mosaic attenuation. It's pretty. So just a nice case of CTEPH with more peripheral than central disease. And that is what I have for the week.
Yeah, it's interesting. There's still a lot of controversy about CTEPH, what actually happens, and some people that think the microvascular disease in the lung is part of the condition, and sometimes that dominates the clinical picture rather than the central clots that we typically look for. So I think what we don't know about that entity exceeds what we know about it. That's a very interesting picture that you showed.
Yeah, it was impressive, the discordance in the CT, but it correlates with the mosaic attenuation. So, all right, well, thanks again, and we'll chat next time.
Thanks, everyone.
Bye-bye.
Thank you.
Thank you.